late 50s, early 60s. The incidence increased during the AIDS epidemic because of immunodeficiency. It's really about like 1 to 2 cases of primary vitreoretinal lymphoma per million per year. So it's quite rare to see it. There's no known racial preference. And as we said, immunodeficiency and immunosuppression are risk factors. It's usually 80% bilateral and it's asymmetric. Usually one eye is worse than the other. Most commonly on pathology, you see a diffuse large B-cell lymphoma. You can see T cells and natural killer cells and indolent B-cell lymphomas as well, but they're more rare. I want to talk about one of my favorite patients, actually. She is a 42-year-old that in 2020, when I wasn't here, presented with floaters in the right eye. I think she was referred from outside to Dr. Oliver. Exam was consistent with vitreous cell. She had retinal whitening and decreased vision in the right eye. Her past medical history is notable for an Arnold-Chiari malformation. She has obesity. Otherwise, really, everything else is unremarkable. So given that she had unexplained cell for a while in one eye, what do? You do a vitreous biopsy that showed an abnormal collection of B cells. IL-10 was elevated to 1249, and we were unable to get IL-6 in mid-88 just because not enough sample, inadequate sample. And CSF sample was also had increased IL-10 levels. So based on this, it was decided that basically it kind of met the diagnostic criteria. Again, there's a delay in diagnosing primary vitreoretinal lymphoma because they're usually masquerading as intermediate and posterior uveitis. Usually they have had prior steroid use that makes your kind of biopsy more challenging to get. So the criteria are IL-10 to IL-6 ratio is elevated more than 1. Usually mid-88 is specific for vitreoretinal lymphoma, and the cytology is to show kind of an abnormal population of B cells or any kind of an abnormal monoclonal population. So given that she presented with one eye, so usually you would do a local therapy. So she has involvement in one eye, we did the vitrectomy and we started local therapy. And if it relapses, then you repeat it. So now this is what happened. So she had local therapy in that eye. She had 8 intravitreal methotrexate injections, and this is how she responded. Does any of the residents want to describe any of the images they see? Yeah, you can see the RP involvement and easy loss. And her final visual acuity is actually 2125 eccentrically. So we can talk about a primary versus secondary vitreoretinal lymphoma. It's 26 to 48% of them don't have CNS involvement at presentation, but usually different numbers in different literature. 60 to 90% will progress to CNS involvement from 8 to 29 months. Back where I trained, Dr. Marr would be like, if they have vitreoretinal lymphoma, you just have to wait for the CNS lymphoma. It's there, they just haven't seen it yet. In some, about 25 to 40% of them present with concurrent CNS lymphoma, and 26 to 34% might have a secondary intraocular lymphoma that might be systemically, that is kind of a metastasis to usually it's a choroidal met from the systemic lymphoma. So she goes along, and 1 year later, she has this mass in her putamen that is suspicious. They did a biopsy. Unfortunately, it was inconclusive. So at this point, we're still calling her local disease in one eye. And she does not receive systemic chemotherapy. We talked about this. Usually they present with posterior uveitis and vitritis, 50%, anterior and posterior uveitis and 22%, and chorioretinitis about in 20% of patients. That's how they usually present. So she presents to me, this was September of my first year. She presents as an urgent visit to my clinic, explaining exactly as a curtain coming down. That's exactly what she said to me. And I was like, yes, an RD before I even looked in. But I look in and I was like, oh, you have vasculitis. So I was like, let's order an FA. And when she presented, actually, surprisingly, she had no vitreous cell on exam. She just presented with this and she described it that it's very rapidly progressing. And she was describing a field cut in that region. So we got the FA, and I'm seeing, she has vasculitis, essentially. And you can see on the optos that she had vascular sheathing, very prominent vascular sheathing. So I called Dr. Oliver and I asked, what do I do? Do I give her steroids, or do I just not give her steroids? And as we decided that we want the vitreous biopsy to give us a decent result, so we decided not to give her steroids. However, she was calling almost every day over the weekend because this was rapidly progressing and really affecting her vision, and that was her only good eye. So we booked her for a vitreous biopsy on like 4 days later to do that. So our vitreous biopsy, given that there was not much vitreous cell, did show an elevated IL-10 to IL-6 on this sample. We were able to get both IL-6 and IL-10. Unfortunately, we weren't able to detect abnormal B cells. And the vasculitis, really, we gave her Kenalog, intravitreal Kenalog, and we put her on high dose prednisone, oral prednisone, 60 milligrams. It really did progress. And she was definitely noticing it. At this point, we weren't able to get an LP due to her Arnold-Chiari malformation. So she only got one LP. That was in 2020. And we decided that this is a systemic disease, of course, with our neuro-oncology colleagues. And she was admitted inpatient and started on the Rituxan, methotrexate, vincristine, and procarbazine. It's a 7 cycles that they do here. And concurrently, we're giving her intravitreal injections. She got 8 rituximabs, and we gave her 18 methotrexates. She's a very, very very aware patient. So she would tell you when we wanted to space out her methotrexate injections, she was like, no, this is not working. So we would go back to weekly. She did develop, at the end, we were able to space her out every 2 weeks, but initially she was getting probably 12 every weekly injections, and she's coming from 3 hours away. And when she was inpatient, I think all the fellows were injecting her as an inpatient. Despite all of that, she did get a decrease in vision. So this is what she presented. She came in the left eye, she came in with a 20/20 vision. And every month by December, we were at 2100. And you can see that kind of the easy line irregularity and RP involvement of this disease. And this is despite getting the systemic chemotherapy. And this is the fundus autofluorescence. You can see that it's progressing pretty quickly as she was describing it in her field constriction. In 2 weeks, it's almost, past her phobia. So given that she progressed on the 7 cycles of RMPV, the oncologist decided to consolidate with autologous stem cell transplantation, which she went through, and they started her on ibrutinib, which binds to a receptor on the B cells, and they use it in B cell lymphomas. Of note, unfortunately, she was allergic to the ibrutinib, and they challenged her with a half dose as well, but she couldn't tolerate it, so she had to get back on the steroids. And apparently, one of the complications of ibrutinib can be CME. So she did develop post ibrutinib CME, and this is the last OCT that that I have of her. And Dr. Oliver gave her 2 Avastins. This is in late August of this year. And she's still, coming. She has the brightest attitude. I think the risk factor for this patient for getting this is she's incredibly nice. And so she's coming in with a great attitude, and she's doing great at this point. Well, great relatively, but she's doing well. I did want to talk about the vitreoretinal lymphoma surveys at CU. They have been all treated with maximum local and systemic therapy to achieve clinical remission. The number of primary vitreoretinal lymphoma patients was 20, 14 are still alive. Of the 6 that deceased, none got the autologous stem cell transplantation. And of the secondary and relapsed diffuse large B-cell lymphoma with eye involvement, we have 10 patients, 9 are alive, and 1 patient deceased because they were ineligible for autologous stem cell transplantation. So these are the unanswered questions that we have. What is the upper age limit for doing an autologous stem cell transplantation? And duration of timing of the intraocular treatment relative to the IV chemo, because that was a question we had with this patient. How often, how much do we do this? The intravitreal methotrexates are not benign. She did develop some corneal toxicity that resolved when we stopped it, but it's definitely not benign. And what's the protocol for isolated unilateral ocular disease? So I'm gonna just, I want to thank everyone, and I'm gonna hand it over to our speaker here. Any questions?
Okay, thanks, Maryam. Thanks for summarizing a complex treatment course for this patient. I think there are many things about this case that highlight some of the challenges in the diagnosis, the local management, and the systemic management of this disease. For the residents and the applicants and fellows, typically this is a disease that you've read about, that you may have heard 1 grand rounds about, and then you may hope that you never see it again, or if you do see it, it will be the one time in your career that this occurs. So we typically think of intraocular lymphoma as something that is wildly rare. Interestingly, we've, over the last 2 years, seen a big spike in the number of cases, both internally as well as by referral from the surrounding region. So it may not be quite as rare as we all think. And, one of the classic things about the presentation of lymphoma is that there's a delay of 1 to 2 years from the time it was initially suspected, or at least that the patient had some uveitic symptoms, until the diagnosis is definitively established. And there are many things that lead to that delay in diagnosis. This is one of the hardest diseases to definitively diagnose, certainly that I take care of. So I think it is very useful for everyone to maintain a high clinical suspicion that lymphoma should be on your differential diagnosis of uveitis that has an otherwise negative workup, particularly an intermediate or posterior uveitis. Also think carefully about how you initiate treatment. For many patients with complex uveitis of unclear etiology, at some point along the way, some helpful person has decided, let's try to give some steroids to help this patient because they continue to clinically decline. If you want to make the yield for any of our diagnostic techniques diminish, give steroids. They make it a lot harder. And in fact, we have had several cases where it was absolutely classic for intraocular lymphoma, and we could not establish the diagnosis using just diagnostic vitrectomy. And instead it required, in one case, actually, we didn't get the diagnosis until it progressed to the patient's brain. In other instances, we've had to get tissue diagnosis with a retinal or a chorioretinal biopsy. And so I think as the suspicion for this disease arises, it's very worth just reaching out to your uveitis colleagues or your oncology colleagues to make sure that deliberate steps are taken to try to establish the diagnosis. Maryam highlighted some of the diagnostic data that we had. This patient eventually wound up with bilateral vitrectomies. Her initial vitrectomy established a high interleukin 10 level, but other specimens were not available from that specimen at that hospital. And this is very common amongst the patients that I take care of who have undergone vitrectomy. Frequently, we have some, but not all of the data. And that's because the diagnostic labs that we send in the OR are extremely particular for how they have to be handled. And our fellows have become very well versed in this, and thankfully our OR nurses are finally becoming comfortable with it. But each specimen goes to a different lab. It's a different destination, multiple send-out labs. Two of them, the cytokines, the IL-6 and the IL-10, have to be snap frozen on ice because the levels diminish very quickly. So they have to be undilute specimens, and then they have to be processed or frozen. So because of all of that sensitivity, if you are performing vitrectomy to diagnose this disease, your lab has to know to expect that the specimen is coming and already be prepared for how they will handle it. Once we establish the diagnosis, then we face all the challenges that we did with this individual who showed marginal response, clinical remission, but with scarring from local chemotherapy only. And then as she relapsed and progressed, which presumably occurred in her brain, even though the brain biopsy was negative, in addition to the subretinal disease, it showed the fact that this can be a fast disease. It's not solely a slow and indolent disease. Thankfully, ultimately, she has been stabilized. She's now about 6 months out from her stem cell transplant. All of our other aggressive measures in terms of local therapy really were ineffective, and her disease did not slow until she underwent that stem cell transplant. She had the very unfortunate reaction to ibrutinib that left actually both eyes with that very moth-eaten CME look that Maryam showed, and it hasn't responded to either anti-VEGF agents or steroids. So this is a disease that can lead to bilateral blindness or bilateral visual impairment, and it definitely, if it progresses to the brain, can lead to death. So take-home points are maintain a high clinical suspicion, and then think very, very deliberately about how to perform your diagnostic workup, because sometimes you only get 1 or 2 good chances to establish that diagnosis before you initiate treatment. So the sooner the better. If there are cells in the other eye, think very carefully about going ahead and getting sample on the other eye in order to be able to know if this is unilateral or bilateral disease. If it's bilateral disease, presumably it's transited the brain, and so that argues more for systemic chemotherapy rather than just local chemotherapy. So a few brief comments there. Any editorials from Hakan?
No, probably I so agree. This is very difficult disease, very challenging disease. And then if you look at, there is always a delay in the diagnosis. For ocular oncologists, diagnosis is always challenging. Treatment is challenging. But I'm going to talk about some things that a little bit different, make the diagnosis maybe a little bit easier, And then the second thing is how to follow the disease. Like you are looking at literally to the vitreous and then looking, hey, is there a cell here? Is there not a cell here? How is the retina is looking? Your judgment regarding your response to the treatment is always question in your mark because there is no definite test. I'm going to mention a little bit couple things that I'm trying to do. Can we come up something objective rather than totally subjective, our clinical examinations, basically? Maybe it might be helpful a little bit in the future. So I don't want to spoil it, but I just want to.
That's great. Good. Thanks very much, Maryam. You want to set up? So while Hakan gets set up, I'll tell you just a little bit about him. I'm really pleased to have Hakan Demirci join us as our invited Grand Round speaker. Hakan currently directs the Ocular Oncology Service at the Kellogg Eye Center at the University of Michigan. Hakan's originally from Turkey, where he attended medical school and did his first ophthalmology residency. When he came to the United States, he worked with multiple ocular oncology groups. And when you look at his publications, you will see how many folks that Hakan has collaborated with over the trajectory of his career. He was a Shields Fellow and then stayed on staff in Philadelphia with the Shields Group. He ultimately moved to Michigan, where he completed an oculoplastics fellowship and then an ophthalmology residency, and then joined the faculty at Michigan in what year?
At the end of 2010.
In the end of 2010. Dr. Demirci has nearly 200 peer-reviewed publications. And if you look at his co-authors with whom he's worked, it's really a who's who of folks who've dedicated their careers to dealing with neoplasms in the eye. And so the body of your work is substantial, and your contributions to the field are really great. Today, you'll hopefully illuminate us just a little bit about this challenging and very rare disease, but we look forward to spending the day with you. Thanks, Hakan, for joining.
Thank you very much for this nice and kind invitation and introduction. I'm very honored to be with you today and then spend the day today. Thank you very much for all your hospitality. My father always asked me, like when I did my residency in Turkey, I moved to the United States, he used to ask me that, what are you doing? I'm like always asking him that, like I was always telling him that, hey, I was a resident first, I was a fellow first. He said, okay, that's good, you will finish your training and then you will be a doctor now. And then I said, no, I am doing another fellowship. Then he was asking, like, when are you going to get a real job? Like, you are always training. And finally, it takes like, I don't know, one decade, I guess, to get the real job. So today, I'm going to talk about vitreoretinal lymphoma. It is, and these are my financial disclosures. So lymphoma can affect any part in the eye, interestingly. Like it can affect periocular structures, like the orbit. When it affects the orbit, it is the most common orbital tumor in adults, actually. Less commonly, it can affect the conjunctiva. And when we look at the intraocular structures, it can affect the uvea. Then we call it uveal lymphoma, which is the mostly low-grade lymphoma, which is the like marginal zone or follicular lymphoma. Or it can affect the vitreous and retina, which is different from the uveal lymphoma, actually. Then we call it vitreoretinal lymphoma. This is totally different disease than the uveal lymphoma. It is a high-grade lymphoma, mostly the diffuse large B-cell lymphoma, and associated with primary CNS disease or the systemic diffuse large B-cell lymphoma. Yes, it is like, it is although if you look at the literature, I definitely agree with you. Like also in my practice, in recent years, I start to see an increase in the incidence. It is, I think, all over the world, we are observing that. Although the incidence is increasing, it is still a rare disease. Like around, maybe they're estimating right now, maybe 400 cases per year in the United States. But it is a wolf among the sheeps, basically. It is in our differential diagnosis for all of our inflammatory disorders. When they ask you a differential diagnosis, you always mention the vitreoretinal lymphoma in all your inflammatory disorders. So it's an important disease because it has important consequences. So at presentation, as we see in the previous case and then in our practice, CNS involvement is present about 16 to 34% of patients. If you look at the flip the coin, and if you look at the CNS lymphoma patients, about 15 to 20% of CNS lymphoma patients present with the vitreoretinal involvement at the time of presentation. So if you follow this vitreoretinal lymphoma patients, about 50 to 90% of them develop CNS disease in 2 years. So the CNS involvement and then the eye involvement is very interesting in this disease. And maybe this is a variant of a CNS disease. Maybe there is some kind of a correlation in between them. I think as the time passes, we will learn about it. So how we can recognize this valve? What are the things that we learn over the years? Like, it is mostly seen in patients older than the 50 years old. Different from all other inflammatory disorders. This patient comes with floaters, painless loss of vision, but they don't, the redness, they don't have conjunctival hyperemia, they don't have photophobia. This disease is usually bilateral at presentation about 60% of the time, but they develop disease. In about 20% of the patients develop bilateral disease during their follow-up. Look at the signs. Maybe these signs will help you to recognize that valve. In the slit lamp exam, you see keratic precipitates and the mild anterior chamber inflammation. It's typical anterior, it's just anterior uveitis, basically. But different from the anterior uveitis, we don't see so much anterior synechia. We don't see that the iris depigmentation. We don't see so much posterior synechia or scleritis, those kind of the inflammatory signs. We don't see it with the vitreoretinal lymphoma. When we look at the vitreous and the posterior segment, we see all this vitritis with lots of vitreous cells in the form of sheets or clumps. And then when it involves the retina, you can see all this multifocal, creamy, yellow-white, deep or outer retinal lesions. They can be really prominent, as we see in this case. They are huge, they are prominent, difficult to miss. But look at the down picture, the picture on the below, and they can be very, very tiny that you got to look at extremely carefully, very, very in detail. So it is interesting. If you see a patient that comes with inflammatory disorders or vitritis, if you see this much infiltration, the vitreous infiltration, you should see some kind of a macular edema. But these patients, they don't develop so much macular edema, different from the vitritis. That's a kind of helpful for us to recognize this disease. As we see in the previous case, like the retinal vasculitis, this is a kind of not at the presentation, but you start to see it towards the end of the disease when the disease starts to get really, really advanced. Or the other findings like retinal hemorrhage, retinal detachment, or necrotizing retinitis. These are like at the end of the disease, basically. So this is how it presents. What are the signs how do we diagnose? What things helps us? The autofluorescence really helps us. This is one of the findings that we see the granular hyper and hypo-autofluorescent pattern. The hyper spots means active disease. There is lymphoma over there. But if you look at that dark spots, they are kind of an inactive disease. The disease is regressing. In fluorescein, it is very typical, this round shaped hypofluorescent lesions. That is, they call it like leopard spot. That's very typical for the vitreoretinal lymphoma. If you look at the OCT is very wide variety. They can be like the nodular hyperreflective lesions at the layer of retina or at RPE layer. They can be infiltrates. They can even involve all of the layers of the retina, like as we see in this case. You can see that the subretinal infiltrate, RPE infiltrate, and then the whole involvement of the retina. This is very typical for the vitreoretinal lymphoma. So these findings really helps us. But I like the ultrasound also. I really like the ultrasound. In the ultrasound, you can really see the vitreous sheets and vitreous clamps and vitreous veils, basically. And then right now, we are routinely doing in all our patients, regular B-scan ultrasound and the UBM. And then we are seeing that the involvement in the vitreous is not only in the posterior vitreous, like as we see in this B-scan, but if you look at the UVM, they go all the way to the pars plana, actually, very anteriorly. why it is important. So when I ask my retina colleagues to do the vitrectomy for me, I ask them, please clean the vitreous base. Just do as aggressive as you can do on the vitreous. Because this is what I start to notice, that some of our recurrences, they are developing in the posterior capsule, actually, just behind the lens. Like this was a gentleman, 71-year-old gentleman, diagnosed with vitreoretinal lymphoma, treated with intravitreal methotrexate and rituxan injections, did very well for 9 months. 9 months later, he came said that, hey, I have these floaters, my vision is decreasing. And as you can see on the slit lamp, you look at that, the posterior capsule is full with the cells. So where did they come from? We look at the UBM, and then you can see the B scan. You can see that in the UBM, the cells are here actually. So they were hiding somewhere in the pars plana area that our treatment maybe the injections didn't reach that area. And then it just recurred. And then so we try a little bit of different things for this patient when I try to give the injections directly to the posterior capsular area, just behind the lens into the anterior vitreous rather than going to the posterior vitreous. But maybe this is one of the hiding places for this disease, just to recur when we are treating. As Scott said, the diagnosis is really challenging in these cases. Like classically, we say that, hey, do the vitrectomy, collect the vitreous, and then send it to the cytology, they will do it for you. But it doesn't work like that way, unfortunately. It doesn't work that way. You really need to be a little bit lucky and a little bit a really good infrastructure, or the patient, the cytopathologist and the lab that you can trust. Because you are doing a vitrectomy, you are literally cutting those cells. They are like you are chewing them. They lose their old features. There is lots of inflammatory cells inside near the lymphoma cells. So when the cytopathologists look, they cannot make the diagnosis. And then they just tell you it's inconclusive. And then they give some kind of a gift to you to make a decision that you scratch your head at the end of the day. Like there are some, if you look at the literature, NEI study shows that, oh, sensitivity is 81%. Specificity is 99%. But if you look at the other parts of the studies, for example, Japan, they say their positive rate is about 45% actually, which is, I think my guess is our rate is around like 80% or something, 70 to 80%. And we are a little bit lucky that we have a very good pathologist actually. But this is very, very difficult diagnosis. And then some of the cytopathologists, they don't want to call the lymphoma diagnosis just based on the cytopathology. They want you to do something else. They want you to give them another supporter. Like flow. Flow was an important thing for a long period of time. And for lymphoma, the people who does plastic, we always, when we do a lymphoma biopsy or biopsy for lymphoma, we always send the specimen for flow cytometry. That's important. But when you send the vitreous to the flow, the yield is really low. We look at just a quality control for our cases, just to see where we are in the flow cytometry wise. We look at we get only positive results in 1/3 of our patients. In 2/3 of our patients, either the cells were insufficient or it was negative. So so it didn't work actually. The flow doesn't work. So at this point, I will come a little bit later, but I'm not sending any cells to the flow at this point. I stopped sending cells to the flow. It doesn't help for anything. It's just wasting your specimen basically. But we do lots of what we call to look at the clonality of the cells, because clonality is important in diagnosis. For lymphoma, to put the diagnosis of the lymphoma, you have to show that those cells, the B cells, are clonal. They have to be proliferating. The same cell is proliferating. They are not polyclonal, multiple cells. So we do this immunoglobulin heavy and light chain molecular clonality. We look at them, and then this, when you look at this clonality based on this is a PCR test actually. If you look at based on the immunoglobulin heavy chain and light chain, then the sensitivity is a little bit higher, increasing. The other is the interleukin 10 and interleukin 6. Why it is important? Interleukin 10 causes the cancer. It's a growth factor. 6 is inflammatory factor. So if it is lymphoma, 10 has to be up, 6 has to be low. That's the logic. But, and then if there are some studies in the literature, they say it's 95% sensitive, 95% specific. But as Scott says, these are proteins. You take the vitrectomy in the office, in the clinic, I'm sorry, in the OR, and then you give the person to do your MA or technician nurse to send to the lab. So she calls, all the proteins are dying. Meanwhile, it is waiting over there, someone to transfer from this to the lab. It goes to the lab, technician is not there, it is still the waiting, and then you are losing everything basically. So when I started in Michigan, I started to establish this IL-10 and IL-6. It never worked for me. I mean, we sent specimen to the Mayo Clinic, we sent some other labs. It never worked for me. So I stopped. At this point, I'm not doing any IL-10, IL-6. It is failure for me, basically. But what makes me more excited in these days is the molecular genetics side. Makes me very excited. I think this is one of the biggest changes is happening in the field. There is one mutation that I will talk a little bit more detailed, MYD88L265D mutation. What is this MYD88? The name sounds really good, MYD88. So it is a kind of an adapter protein. It is an adapter protein. It's an adapter protein. One side is the toll-like receptors, and then the other side is this interleukin signaling pathways, actually. So, and then this interleukin signaling pathways goes to the NF-kappa pathway, which is the main pathway in lymphoma. So this is one of the main proteins that plays in the role for the lymphoma and diffuse large B-cell lymphoma and some other inflammatory conditions also. So thanks to our neuro-oncologists, about 20, 25 years ago, they found that this mutation, MYD88 mutation, in the CNS diffuse large B-cell lymphoma patients. They found that these patients carries the MYD88 mutation, and also they have, if you look at the copy number, they have CDK and 2A loss. So these are two things that starts the process of the CNS disease. And then there are some animal models right now. They changed the MYD88, they changed CD79, and then the lymphoma forms in the animal space. So these especially MYD88 and then CD79B are important mutations. And now, if you talk with our neuro-oncology colleagues, they are subclassifying some of them, these cells, based on these mutation profiles. They look at certain genes. Based on the certain genes, they classify the types of the lymphomas. They make some differences. So if you look at the CNS, how often this MYD88 is present in the CNS lymphomas? It is about 66% of CNS lymphoma patients carries this MYD88 mutation. That's not bad. But thank God to Dr. Polito from the Mayo, that I have big credit and big respect for him. He first, about 6 years ago, he first detected this mutation in the diffuse large B-cell lymphoma. This was a PCR test. They found that it's a high incidence of MYD88 mutation in diffuse large B-cell lymphoma. And then after that, about 5 years ago, we used next-gen sequencing, actually. And then this was our first time trying to figure it out with Dr. Rao and Dr. Johnson. And then, so we found that in our group, it was almost like 75% of our patients carried this mutation. And then they also, all of them has the loss of CDK and 2A. This was our first findings. And we were a little bit excited about this one, actually. Then can it give, and this was based on our stored Vitreo samples. And we were like thinking how we can use this in our diagnosis, and then can we make it a little bit easy for us? And after that, there are lots of studies came into the, and different parts of the world, different studies came into this topic. And right now we're around like 95 patients is reported in the literature. And then cDKNA loss is around like 85%, we know. MYD88 mutation is about 75%. And there are different mutations, PM1 and the others around ranging from 75 to the 44%. So let's use this information in our diagnosis. For example, this was a 71-year-old male. He came with the decrease in the vision and then the cells in the vitreous in the left eye. Did the vitrectomy, typical cytopathology is inconclusive, like that you cannot have diagnosis. But look at the test, everything is pointed out towards the vitreoretinal lymphoma. So you can see that OCT findings, you can see all this autofluorescence, vision improved, so the patient is happy. But we couldn't start the treatment because there is no diagnosis right now. Clinically lymphoma, but pathologically not lymphoma. So 2 years passed, the patient comes to the emergency room right now with the severe loss of vision in the left eye. And then there is a brain lesion that, as you see in the MRI, showed an enhancing lesion abutting the right optic chiasm. They did the LP, it was diffuse large B-cell lymphoma. When we look at this sample backwards, it was his MYD88 was positive actually. So if we had the MYD88 at that point, 2 years ago, can we have this diagnosed, this patient? Can we start the treatment? Yes, definitely yes. Can we change the prognosis? Maybe not, but at least we will have, we will know the diagnosis. Maybe we could have been follow him much more frequently regarding his brain and everything. So this is what we do right now. We do the vitreous biopsies. When they do the vitreous biopsies, they decrease the cut rate significantly low. And then first biopsy, first sample is about a cc, very undiluted. 1 cc, we take without opening any infusion, just take the vitreous. And then in this undiluted, half of them I send it to the cytopath. The other half goes to the molecular diagnostic. We look at the immunoglobulin H and immunoglobulin K, which is the light chain and heavy chain molecular clonality. And then we look at the MYD88 L265 mutation. And then after that, we turn on the infusion. And then I ask my vitreoretinal colleagues to make a very aggressive vitrectomy for me to clean the vitreous space. And they did a really good job actually. So, and also, and I'm taking the anterior chamber tap. I do the aqueous humor tap, anterior chamber tap, and collect the aqueous humor. And then they are looking at the MYD88 in aqueous humor too. And so this aqueous humor collection is much more exciting for me right now because the vitrectomy is a surgery. It's difficult and it involves things. But can you think about that, a test? You can do it in the office. Just do an AC tap, collect some aqueous humor, look at some marker, and make a diagnosis or follow the patient. I think this is possible for lymphoma. I think this is where we are coming to that direction. This is how I do it, for example. I do a AC tap, get about 0.2 ml aqueous humor, and then we send it, and then we do real-time PCR on these patients. This is the first that we just recently published this one. We have around 11 eyes. And this, I collected 11, we have about 21 eyes. 11 of them, half of them, the sample, the aqueous humor was collected at the time of vitrectomy. The other half is collected at the time of, at the office or in the hospital bed. The patient has the CNS lymphoma. Our fellows just went there and then they did the AC tap. Our resident went the AC tap, collect the specimen and send it to the microdiagnostic. So look at that, 83% of them was positive for the lymphoma. So if you do a quick AC tap, you have a test that you can come up with almost 80% positivity, make the diagnosis. If you find the MYD88 mutation, in the anterior chamber in a clinically suspicious patient, this is lymphoma basically. So it makes me very exciting. And sometimes like I start to see these patients in the office in these days, they sent me to rule out lymphoma, rule out inflammation. So what if you do this test in the office much more commonly and then send it, if it is negative, plus your clinical suspicion, it might really help you actually. We do for this one right now, first we were doing the cell-based. Right now we move also to the cell-free DNA. So we are performing our PCR both on cell-based and cell-free DNAs right now. So how we treat the lymphoma? I mean, we heard a little bit ago, if there is only eye involvement, or if it's associated with the CNS involvement, we try some local therapies basically. One of them is external beam radiotherapy, classic years and years we did. The others are the intravitreal chemotherapies. The two famous drugs are methotrexate and rituximab. And of course, the systemic therapy is over there. Radiation, we give a high dose radiation to these patients. Like, I'm sure that you are hearing all this low dose radiation. It's a fun name is the boom boom therapy, like just get the very low dose, very low 2 sessions of 4 gray, very low two times radiation. But this is not for this type of a vitreoretinal type of lymphoma. That's for mild lymphoma. It's the low grade lymphoma. This is a high grade lymphoma. So you give 30 to 45 gray. So when you give this much radiation, you develop some side effects, cataract, dry eye. Almost 12% of patients may develop radiation retinopathy. So that there are some side effects. So we develop these intravitreal injections. We do it like we see in this little bit in these patients. One of them is, thanks to the group from Israel, is Dr. Pierre and Dr. Frankel, is that the methotrexate, how they do it, bi-weekly 4 weeks, every week for 8 weeks, monthly for 9 months. If you count 25 injections more than a year, it is difficult for our Michigan patients to come to me twice a week or every week. It is very difficult for these patients. So the other injection is rituximab. They give these injections, patients get the injections weekly or monthly. And then it is a little bit more high complication rate. Maybe it is a little bit less effective, but a little bit more complication rate. So what I do basically, I combine these two things. So intravitreal methotrexate and rituximab injection. And I decreased my injections to do monthly injections. So the patient can come once a month, get 1 injection, come back later, get another injection, come back another time. And then, so how is our recurrence? How is our results right now? We see about 82% complete response. About 18% of the patients develop recurrence in around like 4-year follow-up right now. So, and then this is the protocol that I'm develop right now after I learned a little bit more about the AC tab and then the aqueous humor MYD88 mutation. So we give the injections to the patients. Usually they get 3 injections, monthly 3 injections. I wait about a month or so. I do the AC tab and look at the MYD88 mutation. If it is negative, then I just observe. I don't need to do, just observe basically. If it is positive, then we start to discuss about, shall we repeat the methotrexate? Shall we give melphalan? Shall we give radiation? So the follow-up of these patients was always a difficult thing. Like, what is the, like you see, just you are depending on, as I was saying, like your clinical suspicion. There was no objective testing. There was no like, hey, did we really treat this patient? Didn't we treat this patient? And things looking okay. But right now we have something that we can assess if the patient responded, not responded. And I tried this philosophy actually. We have so far, this was the first publication. Now our numbers are a little bit increasing right now. We are around 8 patients we tried this one. 7 of them after treatment become MYD88 negative in the anterior segment. And then they are almost like almost 1 year, close to 9 months to a 1 year follow-up right now, and there is no recurrence on that. One patient was I look at it, we did the injection, clinically looks really good. I mean, cells disappeared, his vision is good, but MyD88 positive. So I just watched this patient. I was so hesitant, shall we do anything? So this was the patient, like came first, 2070, we did vitrectomy, did the methotrexate and rituximab, vision increased. I did the AC tab, positive. So I said, okay, let's just wait a little bit, what's going to happen? 6 months later, it came back. You can see on the ultrasound in the periphery, the disease is coming back. So maybe this patient, I should have been more aggressive. Right now, in another patient, I have the same story. I'm becoming more aggressive right now. And then I'm treating them without waiting any clinical recurrence. So maybe this will be, I think, this anterior chamber MyD88 mutation, looking at the mutation can give us some ideas, basically, some help, some kind of a surrogate. And then the systemic therapies are developing in these days. I mean, high-dose methotrexates, CHOP regimens, the ibrutinib, and then the stem cell transplant. An interesting thing about this ibrutinib, I'm going to say one word. Ibrutinib is one of the new coming medications, and it is working especially in the patients with the MyD88 positive mutations. So maybe down the road, we will have some medications, some targeted therapy for the MyD88 positive vitreoretinal lymphoma patients. That will be coming. So, but keep in mind that when I started years ago, we always used to say that CNS lymphoma patients does bad, but their survival is increasing actually. Our neuro-oncology colleagues doing a really, really good job. I have patients 6 years, 7 years, 8 years that they are still alive. And then studies so far show that the local ocular therapy could improve the disease control, but maybe no effect on survival. And there are some studies right now, maybe combine the ocular and systemic therapy. This way, maybe we will delay the CNS disease and then maybe improve the survival. I think time will show right now. So just a quick summary. This is seen in the patients older than, this vitreoretinal lymphoma seen in patients older than 50 years old. It usually comes with mild anterior inflammation, vitreous cells. Look at the patients with vitreous cells. Cytology is really good, gold standard right now. But this MyD88 L265P mutation in the vitreous or anterior chamber is kind of interesting. And I think it is becoming some kind of a liquid biopsy. And I think it will be. And maybe this, especially the anterior chamber MyD88 can be a surrogate to kind of screen the patients or to follow the response to treatment. And then the treatments, I think, methotrexate and combination of methotrexate and rituximab hopefully somehow will help, but we will have lots of things to do basically. And thank you very much again. I know this is like hey, this is one of the wolves in the ship, and it is one of the rear zebras, but thanks for listening to me, and then thanks for your hospitality, actually.
Any questions or comments for Dr. Demirci? Alan?
Yeah, that was a wonderful summary. I have a couple of comments. I think the first is that, as UVI specialist in my practice, I always assume there's a patient with lymphoma that I have yet to diagnose. And, the people who are responding well, they're responding well one way or the other. The people who aren't potentially always have lymphoma, and it becomes an increasing challenge to sort that out. But I always assume there's somebody who I've yet to diagnose. A couple other comments. I think you make a really good point about cut rate, but even more important is vitrectomy size. So most of the data from the NEI that's there was done with 20 gauge vitrectomy with a slow cut rate and big chunks of stuff. I think when we move to 27 gauge vitrectomy, we're chopping up the cells, as you say, and we get poorer yields. Especially we get poor yields on cytopathology. And I think that the other markers, I agree, flow is great when it works, but we have more negative flows and inconclusive specimens than we ever get wow, this is a positive flow. The problem with the other markers, whether it's IL-10, IL-6, or MyD88, is that the oncologists, the neuro-oncologists, don't really buy the diagnosis.
Yes.
So, you know, you can have, I mean, I have never seen a patient with a high IL-10 and a low IL-6 who does have inflammation. They might not have lymphoma, but they don't have inflammation. IL-6 has to be up, but they won't buy that. They'll use it as a confirmatory thing. So at least at this institution, a positive MIT-88 without anything else, they'll still tell us it's not lymphoma. And I think that's a problem with the oncology community not really understanding vitreoretinal lymphoma.
Yes.
And we, you know, we have not been able to in 40 years change their opinion.
Yes.
And I don't know how to do that. And that's why we end up doing, say it's localized lymphoma, and then 2/3 of the people eventually get CNS lymphoma. And now they say, aha, it's lymphoma. But great talk.
You are so right. You are so right. I mean, for the buy-in from our neuro-oncology sites was this difficult and still difficult. Like we sometimes recommend them, like, why don't you guys do the CSLP and look at the MID-88 in the LP? But their logic is a little bit right on the other side. I don't blame them also. They say that, hey, like the best series shows almost 65, 60%, or sometimes a little bit more positivity in the CSS. So if it is negative, how I am going to be really sure on this one? And I agree, totally agree with them. But the counterpoint about it is that if you look at the immune privileged sites like testis or eye, the positivity is increasing for this type of lymphoma. I don't know, maybe that's why this vitreoretinal lymphoma and CNS lymphoma, we always say that, hey, they are variant of each other, they are subtype of each other. Maybe, maybe not. Maybe there is some connection, but maybe they are not totally the same disease, basically. Or the eye changes, the immune system in the eye changes the things a little bit. So
I also think the relative ischemia in the vitreous changes the cells, you know, because it's the only part of the body where there's, you know, no vasculature, whereas even the brain,
yes,
there's vasculature all around that tumor. And so I think that impairs our ability to get healthy cells that express the right markers for the oncologist. And I tried for years over my career to change oncology's opinion. And they just, you know, it's got to be a tumor by their definition of a tumor, but this is clearly a cancer.
Along the same point, I think Scott, one of the big contrasts when we are trying to establish the diagnosis, if we have a patient where we have a high clinical suspicion or even positive tests, we have lymphoma inside the eye. My conversation then with neuro-oncology, medical oncology is, where else is it, right? Is it in the other eye? Well, that's our job. And is it in the brain? And how do we prove it? And from my perspective, if I see lymphoma and have confirmatory testing in both eyes, how did it get to both eyes? It had to go through the brain to get there, or at least that's the pathway that makes the most sense. But how do we prove that to justify therapies that are very intense? The local therapy for this disease, for every fellow who's been in my clinic, is crushing. You see these patients all the time, and then you manage the toxicity from whether it's the immune reaction to the Rituxan or the corneal toxicity from the methotrexate. It's very intensive, and we're not even seeing the impact of the systemic chemo administration. These patients are admitted to the hospital for therapy. Generally, they'll push them as far as they can tolerate, up to 7 rounds of high-dose methotrexate-based therapy, usually MPV, R-CHOP if they're older. This is intense. And then a stem cell transplant is even more intense. So I think in defense of that, of being very demanding about making sure that we have the right diagnosis, no one should get a stem cell transplant if they don't have the disease. But to me, the biggest contrast is that we have the privilege of looking into the only organ that has a window, where we are able to detect disease progression with very high degrees of sensitivity. In the images that Maryam showed, where the patient had inexorable subretinal progression over a period of days, we knew that was lymphoma that was marching, or had a high concern that this is lymphoma that's marching, and the challenge was improving it. So we can look in, we can see it, and on some degree of an intuitive level that I think Hakan's touched on and that Alan's touched on, have a sense that this really looks like lymphoma. No one else in the medical establishment believes our subjective assessment there. And so they are burdened by the modalities available. CNS imaging requires probably thousands of cells to be present, whereas we may be able to detect dozens to hundreds, maybe tens of thousands of cells before you have gross CNS disease. And we've seen some of the images today. When there's a large brain lesion, then it's a little more straightforward. It's easier to convince folks. But in an ideal world, we'd find a way to make that diagnosis. And we do so with cerebrospinal fluid. But think of the volume of the eye. I think about this when I'm getting the specimen. We have 4 cc's of vitreous to work with, and some of it has to be undilute to be able to send off our labs. But we're trying to surveil the CSF, which I don't know the CSF volume. Maybe someone in this room does. 90 cc's. Okay, so you've got a large volume. You're taking it from the lumbar region. If it's up somewhere else higher in the brain, you may or may not be sampling the same zone, and we're dependent solely on labs. So we have moved to cytology, flow cytometry, MIGHTY 88, and IL-10 assessments on the CSF, but with the exception of cytopathology, which is almost never positive, it still is a tangential diagnosis. And I think our Doug Nye or Brad Haverkos, I know we're on the call earlier. These are our neuro-onc and medical oncology folks, so they can defend themselves if you guys want to jump in here to chime in. As we've discussed this, they have been willing to consider systemic treatment even without cell-proven CNS involvement. And from my perspective in managing this disease, I mean, there are so many challenges, but the biggest one should be, can we stop people from dying from this disease? Yeah. We actually have therapy that has, with the Sloan MSK protocol, there now exists therapy for diffuse large B-cell lymphoma of the CNS that has changed survival. Yes. That's 4 to 7 rounds of chemotherapy with a stem cell transplant, and survival that's gone from, at 5 years, from 40 or 50% to 70-ish%. So if we ask the question in reverse, why, in which cases should we not apply that therapy? Because if I had these cells and I'm sitting in Hakan's office, I don't want to die from CNS lymphoma. And I think that we have to keep our focus on that through all of our testing modalities to try to help move the survival outcome.
We've been more successful with IL-10, IL-6 here than I guess you have. And we get consistently good IL-10, IL-6 numbers. And I think that somebody who is IL-10 over IL-6 with, and I'm not talking a ratio of 2 or 3, I'm talking a ratio of 10 or 20, with the IL-10 is that much higher, and is MIGHTY 88 positive. What else do they have? I mean, they don't have syphilis, tuberculosis. There's not much other choices.
Definitely. I mean, I think you're right. I mean, also, even if cytopathologists, when they see the cells, they don't want to call the lymphoma that cells. They say, hey, it is inflammatory cells, basically. And then they don't want to diagnose it. They see suspicious cells. They say, hey, I'm seeing these suspicious cells, but I cannot call the diagnosis. So then you have some kind of a problem in front of you that clinically you know what it is, but you cannot prove what it is. And then you cannot start any treatment for it. It is a very, as a clinician, you are like in front of the patient, and then you are the face of the pathologist. You have the face of what's happening in the behind, and then you feel that like helpless, like what I am going to do question, or how can I help this patient question, basically. So I think as we can get more and more of this supportive diagnosis, and then relay our message to the neuro-oncology department, to our colleagues, maybe we will increase our success. But you are right, like I couldn't still convince that regarding if we can get the local disease under control, can we start these patients on some systemic therapy early on that prevent the prognosis of this disease down the road? We are still debating about these ideas, like shall we do it, shall not we do it? Hopefully they will come to the feeling with us, I mean.
Well, and one other thing that I think we all should be cautious about, methotrexate is pretty readily available. It's available in the community. And, for patients who've had logistical challenges in coming down for frequent injections, our VR colleagues in the community have been willing to develop a protocol to administer the methotrexate. It's a cheap drug. It's pretty easy to get as long as your pharmacy will release it. And the challenge, at least in retina, is that now we've all become accustomed to this 32 gauge needle with a syringe with a medicine that's pretty easy to get into the eye in the form of anti-VEGF drugs. So you all have seen cases where people say, well, let's try Avastin and see what happens. Well, this is not a disease where we should let's try methotrexate and see what happens. We'll give 1 or 2 shots. We need to know where we stand as well as we can. We need to have a protocol and a plan. My commitment to the program and to this disease is that I'm not administering intraocular chemotherapy without neuro-oncology knowing about this disease and about this particular patient. Even if the patient's not getting systemic disease, the patient deserves a formal oncology treatment plan before we embark in that direction. And I think that as we follow the patient over the course of their disease, if they do clinically worsen, then it's not a surprise and a blindside to neuro-oncology to escalate therapy with systemic chemo.
This like the protocol of methotrexate protocol, it's always a little bit difficult for me, it is very frequent injections. And then the idea like this, how frequently we should do the methotrexate is, and how what's the scientific base is a little bit just based on experience, basically. It is just, there is not so much science behind why they should get the 25 injection, why shouldn't get the 10 injection or 5 injection, where the line stays. So that's what I'm a little bit moving about this, what's in the literature, frequently inject, and then also in the Rituxan side, Rituxan has a little bit more expensive. Luckily, biosimilar came into the market right now, but it has some side effects. I didn't go into that much, but we have right now about around 25 to 30 eyes that has been treated with this one, with Rituxan. We have 3 patients who developed the sterile endophthalmitis. It was severe very totally sterile endophthalmitis that we were debating about, start thinking that is endophthalmitis. Shall we start let's tap and inject or not, or shall we just follow? Luckily, all 3 just resolved and their vision came back. We have 2 patients who has occlusive vasculopathy actually after the rituximab. Then they have this vasculitis. One of them is at the periphery, and then the other is at the macula. And then, but luckily, both of them, if you give the steroid, in about 2-3 weeks later, everything is just returned back completely different from the other drug-induced vasculitis. I was talking with one of my retina colleagues, he was telling me vancomycin causes retinal vasculitis and it never comes back. But the rituximab vasculitis, they're turning back actually. So I think the idea of that we frequently inject, where we stop, where the end, and how much we inject is, I think we will learn over the time what is the ideal number for this one.
We really don't know. It's very open-ended. Shahar Frankel, who's the lead author on this particular publication, was in town for Arvo this year, and we had a robust conversation for about an hour on this particular topic. So Kobe Pierre is the senior member of that group, and they have done more methotrexate and Rituxan than anyone else in the world.
Yeah.
So their experience with it is absolutely huge. I think that the key things to note are this is the proposed protocol. Very few patients actually finish this protocol because their corneal toxicity becomes intolerable. Usually it's 2 to 3 months in. He has multiple opaque corneas, which he reassures me every single one of them has recovered. So none have required penetrating keratoplasty. But these patients are quite miserable. And note that, that actually it's a treat as long as they can tolerate. So just, here, very few required more than 13 injections. So many patients are not completing this protocol. We've modified this protocol here. Logistically, it has been extremely difficult for patients to follow through with it. So I'm doing weekly injections times 4, and then every other week times 4 more, and then clinical observation. One of the other key points from this publication is that this is to induce local remission of the disease. So they're not treating any of these patients with systemic chemotherapy unless there's definitively proven CNS disease. So yes, it may be a Pyrrhic victory, right? I mean, we've treated the eye, but they still die of brain disease. And you've sort of tortured the patient and yourself along the way and in the process. So I think there's value in inducing local remission, but the eye always has to be on the CNS. And if a patient is undergoing local only therapy, there has to be a plan for serial CSF assessment. And that means multiple lumbar punctures, which, I've not had either patients or neurologists get super excited about, but actually you can protocol it. If you predefine every 3 months or every 4 months, we'll be looking at CSF for markers of progression. That way, if we catch it, we get it before there's gross disease in the brain.
Yeah, I don't want to get into those much about the systemic disease and then the follow-ups, but your points are so right. Like as an ophthalmologist, we make progress in the eye point, but the systemic prognostic points progress is happening, but maybe not as much as that we want to see basically.
Great. Thanks. Good discussion. Thank you for joining us.
Thank you very much.
All right.
Thanks for everything.
Bye-bye.